So in order to order, interpret, understand, it is very important to understand the thyroid physiology. We are very, very familiar with this hypothalamo-pituitary thyroid axis, which is all of us are know it, from hypothalamus, the TRH, to the pituitary gland, the TSH, and the thyroid gland, which secretes the hormones. I wish it was as simple as this, but we know that within the thyroid gland, there are so many steps in the process of thyroid hormone synthesis, and each of those steps are modulated by a gene, an enzyme, or something or the other. But the knowledge of this is very, very important, because when we don't see a straightforward case of hypothyroidism, we really need to go back and look at what's happening. And also, it doesn't stop there. We have the target tissues. We have the deiodinases, which convert the deiodinase 1 and 2, which convert from T4 to metabolically active T3. The deiodinase 3, which converts it to the reverse T3, which is in metabolically inactive form. And as we know, there are several target tissue for thyroid hormones, and each of these target tissue have different expressions and different levels of expression also of these deiodinases. Once again, they also have this receptors in the target tissue, alpha and beta. Some are expressed more in some target tissue. So it's a very, very complex interplay. When we finally see a normal child with a normal euthyroid status, I think it's a miracle, looking at the number of processes that is involved in thyroid hormone. In addition to all this, for entry of T3, we know that T3 is a metabolically active one. There are specific transporters. So it's a very complex process, and knowledge of this is really important when we consider the complex thyroid function test. We know that once it's produced, it is primarily metabolic actions and actions in myelin formation, neuronal migration, and maturation. That is why congenital hypothyroidism, delay in diagnosis is so, can have very drastic consequences on the neurocognitive outcome, and it also has impact on growth. So when we think about the basic tests to diagnose hypothyroidism, we know that it is TSH, T4 levels, and an available free T4. And why so? Because TSH is the most sensitive marker of the thyroid hormone adequacy. A 10 to 15% decrease in free T4. So it's actually a log linear relationship. A 10 to 15% decrease in free T4 causes a 100 to 200% increase in TSH. So for example, if the free T4 drops from 1 to 0.5, it raises the TSH from 0.5 to 50 milli-IU per ml. And the TSH rise, on the other hand, from 1 to 5, it reflects a drop of free T4 only from 1 to 0.9. So I think this is important for us to know, because of mild elevation in TSH, like for example, 6 or 6.5, it may not really be reflecting a major drop in the free T4 level. TSH is a very sensitive third generation immunometric assay, and the functional sensitivity is very good. And it's really important to interpret. As adult endocrinologists, I think all of you are familiar with ordering TSH for monitoring thyroid function, and definitely not so in children. You have to interpret the TSH level in relation to the concomitant T4 and free T4 levels. It's almost like the calcium parameters. Calcium, phosphorus, alkaline phosphatase, and PTH go together, if we say. And levels of thyroid, the total T4 and T3 are circulated bound to thyroid binding proteins. But we know that these are affected by certain drugs, diseases, certain genetic conditions, etc. So free T4 probably better represents the tissue thyroid hormone availability. Should we test serum T3 routinely? We know that 80% of the T3 is formed in the target tissues from T4. And that is also, when there is a hypothyroid state, there is an increased T4 to T3 conversion to maintain T3 as normal as possible. Therefore, measurement of T3 is not useful to diagnose hypothyroidism. But there are certain scenarios where serum T3 measurement is useful and imperative. We'll discuss this later. So when you come to the biochemical diagnosis of hypothyroidism, by logic, when there are the low T4 level, there should be appropriately elevated TSH, which suggests a primary hypothyroidism with a defect in the thyroid gland, whereas a low T4 and free T4 with an inappropriately low TSH suggests central hypothyroidism. Well, this is what we see in most of the reports, and this is the expected biochemical report, but not always. Moving on to hypothyroidism in neonates or congenital hypothyroidism, we know that there is asymptomatic at birth even when there is no thyroid gland. This is because although the fetal thyroid starts functioning from the 12th week of gestation, and there is significant hormone production only by 20 weeks or so, the fetus is entirely dependent on the maternal thyroxine till mid-gestation. So even in thyroid agenesis, fetus is protected from hypothyroxemia by the transplacental transfer of maternal thyroxine. However, untreated congenital hypothyroidism over the next several days to weeks to months progresses on to a full-blown hypothyroid baby, where in the newborn period, they can have prolonged physiological jaundice, lethargy. That is actually quite surprising with Archana's case, and she said the child was very irritable. Normally, congenital hypothyroidism, untreated, they're quite sedate. They're very easy babies, you know. So sleeping all the time, they have a big tongue, wide open anterior fontanelle, hoarse cry, because even the vocal cords are actually edematous, dry skin, goiter may or may not be there, hypothermia, hypotonia, umbilical hernia. More importantly, they don't grow, particularly in terms of their linear height velocity, and they end up with global developmental delay. Of course, congenital hypothyroidism may be associated with some dysmorphic conditions, commonest being Down syndrome, and they can also have other congenital malformations. It's important to look for that, particularly congenital heart defects. So the diagnosis of congenital hypothyroidism, biochemically, we know that the best option would be newborn screening well before any of the symptoms have come. And that can be possible only if we screen all newborns. And primary, we already looked at the diagnostic criteria. And for an etiological diagnosis for congenital hypothyroidism, nuclear scan, iodine 123 scans are the best, but they're not available. So based on availability, technician 99 scan that actually can delineate the thyroid gland well. And in terms of, in cases of dysharmonogenesis, perchlorate discharge tests may be done, but not often done these days. Ultrasonography is a good complementary modality of investigation. We have a slide on that. And in certain situations, serum thyroglobulin or thyroid autoantibodies. So when we look at the etiology, as Dr. Archana alluded to, dysgenesis, which includes agenesis, hypoplasia, and ectopia. Dysharmonogenesis, in our part of the world, this is also quite common because it's an autosomal, most of them are autosomal recessive inheritance, and there's a high degree of consanguinity. Iodine deficiency and transient hypothyroidism in iodine excess state. There is a slide on that, we'll do it with data. And maternal blocking antibodies. Of course, very few cases of central hypothyroidism, even in the newborn period, we can pick up. In our center, we screen using cord blood and very suppressed TSH. Actually, we have been following up and we picked up about 8 or 10 children with central hypothyroidism. And there are rarer causes which can also contribute. They may not present during the newborn period. They can present either in infancy or in early childhood. When it comes to imaging of the thyroid gland, ideally, the technician scan should be done as before the levothyroxine is initiated. However, at no point of time, there should be a delay in treatment because the scan is getting delayed. It can also be done in the first few days when the TSH is elevated. Just last week, we had a patient, we had a baby, newborn baby, 11-day-old, referred from elsewhere. Congenital hypothyroidism, primary hypothyroidism, diagnosed on day 4 with a TSH of more than 100 and very low T4, FT4 values. And an ultrasound done showed a normal thyroid gland. Baby came to us on day 11. The TSH was 38, but was quite jaundiced. So the first 2 days, we focused on giving phototherapy and all that. By the time we repeated the TSH, we just did a repeat ultrasound and we could not see the gland. So we were not sure whether we are dealing with severe hypoplasia or an absent gland, what exactly happened. But on day 11, on day 13, when the TSH was repeated, it was only 23. So we could not do a technician scan. Ideally, within the 2 to 3 days of starting levothyroxine, we can do, or at least, I don't know the reference, but TSH should at least be more than 30 when we actually do the technician scan. Apparent athyrosis, we will discuss this later. So here there is an absent. You do a technician scan, you see an absent thyroid gland, but the thyroid gland is present in ultrasound. That is, there's just no uptake in the nucleus scan. Ultrasonography can be done at any time, but you need an experienced radiologist. And also, even though you have a good poke, you may still miss an ectopic gland. Nuclear imaging and ultrasound is complementary and it improves the diagnostic accuracy. How about knee X-ray? In the very olden times, we used to look at this with an absent femoral epiphysis. It only shows the severity of congenital hypothyroidism. I don't think it adds anything to the diagnosis. So this is a nuclear imaging picture of athyrosis. We can see that in between the two markers, there is no thyroid uptake in the thyroid bed. An ectopia, where you see an avid uptake in the sublingual area. And an enlarged gland. Of course, this child we have to do with the purpurate discharge test, dyshomogenesis. As I said, absent distal femoral epiphysis shows the severity of congenital hypothyroidism. So as soon as we make the diagnosis, it's very important to do the counseling. And the detailed counseling is important to establish a rapport with the family because you're going to be associated with this family for the next several years. And in many of our social situations, anything congenital, they try to blame the mother. So it's very important to make all the stakeholders, parents, grandparents, whoever is there, make sure that we explain clearly. We also, if we have made an etiological diagnosis, discuss regarding permanent, because we know that dysgenesis, thyroid dysgenesis definitely is permanent. And most of dyshomogenesis, but there are certain subsections of dyshomogenesis which we may be able to trial off after 3 years. It's very important to tell the family of benefit of early diagnosis because according to them, this is a totally well newborn baby and you're going to call them back multiple times for follow-up and treatment. So it's really, the counseling is really important. How to administer thyroxine, bioavailability, compliance, and regular follow-up. Treatment is initiation of levothyroxine as early as possible, preferably within 2 weeks of birth. Starting dose is 10 to 15 microgram per kg per day. It's available only as tablet. It is crushed in a spoon and mixed with few ml of breast milk and administered directly. And 30 to 45 minutes preferably before milk or anything is given to this baby. We know that this is only the starting dose. As with follow-up, we have to adjust the doses based on the TSH and the free T4 level, and the dose requirement decreases with age. And in acquired hypothyroidism, we can either follow this starting dose or, in autoimmune conditions, anywhere between 50 to 100 microgram per meter square per day. On an average, the autoimmune thyroid usually require about 80 microgram per kg per day. The treatment goals for congenital hypothyroidism, you need to follow up after starting treatment at 2 weeks and 4 weeks. Thereafter, 2 monthly till 6 months of age, 3 monthly till 3 years, and 6 monthly till completion of growth. At every visit, it's important to ensure compliance. You need to really ask them how they're giving, whether they're giving regularly, check for optimum growth and attainment of developmental milestones. And dose adjustment, unfortunately, we cannot do any adjustment without doing the blood test. we need to do blood tests to maintain free T4 in the upper normal range and TSH within the normal range. No, oversuppression of TSH is not advisable. And we have to explain to the parents that the sample should be taken before or at least 4 hours after the levothyroxine dose. And what does overdose do? In short term, it causes some tachycardia, irritability, and disturbed sleep. However, long-term high doses, we have seen many cases with advanced bone age, learning difficulties, craniosynostosis, and behavioral issues. Coming to newborn thyroid screening, we know that the untreated hypothyroidism has devastating effects on growth and development. And with each week delay in diagnosing and treating, there is a steady drop in IQ as well. As we saw just now, the clinical diagnosis is less than 10% in the first month and around 30% by 3 months. So newborn screening identifies infants with congenital hypothyroidism long before the clinical signs and symptoms appear. And it was initiated in the 1970s, and it became the standard of care in most of the developed countries by 1980s. But the situation is very different in the developing countries. And in India, there's no national universal newborn screening, not yet. However, very proud to say that the state-level screening programs in Goa and Kerala. I was talking to Dr. Vijay Kumar yesterday, and he said it's reaching almost 90% coverage in the government and all the private hospitals as well. And the screening is available at selected districts in few states in India. However, several private hospitals all over India have started the screening programs, which are independently run by each hospital. And with no national level program in India, it's important to encourage and empower everyone who's dealing with children to do newborn screening: obstetricians, midwives, pediatricians, neonatologists, family practitioners. And once confirmed or once screen positive, to refer to specialist. And it's important to develop and publish region-specific guidelines specific for the developing countries. And with this in mind, in 2017-18, ISPE published the locally relevant clinical practice guidelines, and it has been published in 2 sections: Part 1 for screening and confirmation, and Part 2 imaging, treatment, and follow-up. And this gives very clear guidelines about all aspects of newborn screening. Just to summarize that in one slide, the guidelines, ISPE recommends screening every newborn using either cord blood or postnatal blood, ideally at 48 to 72 hours of age. Less than 20 is screened test off. It's serum units. There is a difference between serum units and the whole blood units. You need to, for converting the whole blood units, you need to multiply by the factor of 2.2 to adjust for the hematocrit to get the serum unit. So when you get a thyroid screening report, it's important to see whether it's a whole blood unit or a serum unit you're looking at. So TSH less than 20, it's screen negative, nothing to be done. More than 80, very high likelihood of congenital hypothyroidism. So we need to collect the confirmatory sample and start levothyroxine immediately. Between 40 to 80, we recall them at 72 hours of age. And between 20 to 40, which are expected to be the milder forms or even negative, confirmatory sample is taken at 7 to 10 days of age. And this is just screening. We need to confirm before we start treatment. And the primary confirmation is by taking a venous sample for TSH and T4. Age less than 2 weeks, TSH more than 20, and more than 2 weeks, TSH more than 10, along with a low T4 or a free T4 confirms primary congenital hypothyroidism. And there are cases where there is mild TSH elevation. There is no consensus if you see the various society guidelines, but ISPE recommends if the TSH is persistent above 10 after 3 weeks of age, to start treatment, to monitor carefully and reassess at 3 years of age. And is the screening applicable to all children? Because there is a blunting of TSH surge at birth in preterm infants. So though even every baby is recommended to be screened between 48 to 72 hours, but rescreening is recommended for those who are born preterm, low birth weight, very low birth weight, multiple birth, and ill neonates by 2 to 4 weeks of age. permanent versus transient congenital hypothyroidism. We know that agenesis, hypoplasia, and ectopia is permanent. And any even dysomnogenesis which requires regular steady increase to maintain euthyroid state, we do not consider it to be transient and or give a trial of. But the permanence has to be reassessed in those where the initial diagnosis is made without fulfilling all criteria. And the TSH throughout the first 3 years of treatment remains suppressed to a certain extent, or there is an elevated free T4 with minimal levothyroxine dose changes. In those, we need to give a trial of at 3 years of, beyond 3 years of age and reassess. I just looked. So newborn screening has been going on from July 2001. So it's about 22 years now. Almost the first few children are almost 21 and 22 years. So I looked at the data of a couple of those children. So this is a child with a 10-year-old now, diagnosed in our newborn screening program with thyroid agenesis, and she's on regular follow. As we can see here, her growth is normal and she is in an age-appropriate class. We have not done a formal development assessment. And these are two of our very old, one of the first few, both 21-year-old, just to show their final height. And one is doing MBA and the other is doing medical lab technician course. Not all are success stories. We also have children who are not doing well. So moving on, in congenital hypothyroidism, you need to interpret the thyroid function test with caution. So we will look at a few case scenarios. The first, most important, is to look at the age of sampling. We kept on saying 48 hours, 72 hours, beyond 72 hours. That's because at birth, soon after birth, within 30 to 60 minutes after birth, there is a sharp TSH surge, which peaks on day 1, even up to 100. And it starts declining and returns to normal by 72 hours and beyond. So if we take a sample at, say, about 5 hours or 6 hours after birth, we may get an unusually high TSH, which is actually false positive. So a differential cutoff too, and vast majority of our children, the problem is if you don't screen them when they are in the hospital and following discharge, it's very difficult to get them back. And most of the normal deliveries are actually discharged within 24 hours after birth. So 24 or even 48 hours. So if we need to take a sampling, we need to use a differential cutoff. So between 24 to 48 hours, if you take the sample, instead of 20, the screen TSH cutoff will be 34. And from Lucknow itself, we've shown that the recall rate was significantly reduced when using an age-appropriate cutoff rather than a standard cutoff. You got a call from the neonates, 31-weeker, with a birth weight of 1,400 grams. As you can see here, low T4 and free T4 with inappropriately low, very low TSH level. So this is attributable to prematurity because these children have immature HPT axis and along with immature ability for the thyroid gland to synthesize the hormones. So commencing thyroid, the levothyroxine in this will not be advisable. And compared to term babies, they take about 3 to 8 weeks for this to normalize as in term babies. In addition, these premature babies, as we saw earlier, can also have a delayed TSH elevation. Even if there is a primary hypothyroidism, even up to 2 weeks, there can be a delay in TSH elevation. So it's really important to rescreen these babies at about 4 weeks of age. Another baby, low free T4, again with an inappropriately low TSH. And this baby had sepsis and marked jaundice. And we were called to give an opinion on this thyroid profile and treat the baby. So there are 3 conditions which we have to think of. Most important being non-thyroidal illness. In the past, we used to call it sick euthyroid syndrome. I have a slide on this a little later. And central hypothyroidism. Unlikely, but still we need to consider because it's just baby is just 4 days old. And also this could still be a primary CH with a delayed TSH elevation. So in central hypothyroidism, if we are thinking, if the thyroid profile is suggestive of that, ideally we should see the babies before we see the thyroid profile. We need to look for any midfacial anomalies, hypoglycemia, microcephalus, Visual anomalies at birth is difficult, but these children often have septo-optic dysplasia, agenesis of the corpus callosum, etc. So it's important to screen for other pituitary hormone deficiencies. So ACTH and or with or without growth hormone deficiency, newborn period causes hypoglycemia. ACTH deficiency alone causes cholestasis, and an LH deficiency can cause micropenias. So it's important to start treatment. After, it's important to screen for pituitary hormones, particularly the ACTH. And if hypocortisolism is also present, we need to start cortisol first and then start treatment with thyroxine. And in this condition, it's important to monitor the T4 and free T4 values and not the TSH. And when the baby is ready, it is, if there's a central hypothyroidism, we need to do a MRI bleed. What about exposure to excess iodine? So this was a baby who was operated for dural atresia on day 2 and subsequently started enteral feeding. And day 7 for jaundice, because of jaundice, they had done a thyroid function test, which showed very clearly a primary hypothyroidism. Any idea what the problem is? Yeah. So in the past, I don't think we use a lot of betadine nowadays, but there's a high content of iodine in betadine, and that is an auto-regulatory mechanism. So when they're exposed to excess iodine, it's an auto-regulatory mechanism to prevent excess trapping of iodine during iodine loading. And it only causes a transient hypothyroidism. One way to confirm it is elevated urinary iodine level. And these babies just need a follow-up. Serial TFTs will exclude congenital hypothyroidism. Very often we see this in older children, yes, even in newborn period, mild elevation in the TSH alone with normal T4 and free T4 levels, isolated hyperthyroidopenia. It could represent a delayed maturation of the hypothalamic-pituitary axis. It could be a transient or a permanent CH. Rarely, inactivating mutations of the TSH receptor can cause this. But a Down syndrome diagnosis may not be very obvious during the newborn period because it may not fulfill all the Hall's criteria. But if there is a mild TSH elevation persistent, 2 syndromes which can actually cause that is Down syndrome and pseudo-hypoparathyroidism, just to keep in mind. And the recommendation during the newborn period or in early unit is to commence treatment if TSH level is persistently more than 10 and assess at when the child is about 3 years old. The athyrosis. So this child confirmed to have primary hypothyroidism on day 7. Thyroid scan showed athyrosis, was started on treatment and regularly followed up till 1 year, and the TFTs were normal with minimal dose change. Mother decided to stop it at about 1.5 years of age. And then she came at 2 years with the child having an upper respiratory infection. Completely normal development, growth, and normal thyroid profile. So going back, we had realized that the mother had received treatment for thyrotoxicosis. This is something that she should have picked up in the beginning itself, had received treatment till about 20 weeks of gestation. And currently at 2 years, the ultrasound shows a normal thyroid gland. During the newborn period, had shown an absent gland. So this is a transient hypothyroidism. This actually because of that, it's an apparent athyrosis because of the maternal TSH binding inhibitory immunoglobulin. So it causes transient neonatal hypothyroidism and no goiter. It's important to know this because it's a very high recurrence rate in the subsequent pregnancies, and parents and doctors are to be made aware of this condition. So what is this athyrosis? So if it's a true athyrosis, the thyroglobulin will be undetectable, or when it's just an apparent because of a transplasmal transfer. That is how the ultrasound is also complementary to this. The gland will be shown normally on ultrasound. However, the thyrosis can also be because of a sodium iodide symporter defect. But these children clinically will have goiter. Clinically or even in ultrasound will have goiter, but an apparent athyrosis on the nuclear scan. Maternal thyrotoxicosis, mother on carbimazole, and on day 4, baby has primary hypothyroidism on thyroid profile Very important to know that this is a transient hypothyroidism. We should not start treatment with levothyroxine. And these children, because may develop neonatal graves, we need to monitor the thyroid function test. And sometimes even up to 6 weeks, we need to monitor the thyroid profile to make sure that the baby is well. Another baby, primary congenital hypothyroidism, diagnosed on day 7 with gland in situ, no dysmorphism. At 3 months onwards, baby was noted to have central hypotonia with a motor developmental delay. By 2 years, developed increasing jerky movements and difficulty with coordination, and diagnosed as choriothetoid cerebral palsy. Of course, the biggest blame would be on the pediatric endocrinologist because either inadequate or delayed thyroxine. We often get referrals from pediatric neurologists saying you haven't done your job well. So inadequate or delayed thyroxine replaced in the neonatal period. Are there any other possibilities? So are there any other possibilities? Yeah. So this is when the genetics of congenital hypothyroidism. So in a routine case, we don't need to do any genetic studies for congenital hypothyroidism. But when it is associated with other system involvement, so this child in the past was TTF1, so MKX21 gene defect, which causes neonatal respiratory distress. It can cause hypotonia, ataxia. Similarly, there are a number of genes which are mentioned here with other congenital, other system involvement as well. So particularly when there is any other system involvement, we need to do the genetic test to confirm this, but if it is available. Treatment would be the same. And also in dishormonogenesis, as I told you, for thyroid hormone synthesis, there are several steps, and at each step, it is mediated by a gene. And depending on which gene is affected or which step is affected, from iodide trapping to transport to impaired iodide oxidation, organification, and deiodination, all these steps, based on the gene, we actually can expect a degree of hypothyroidism. Once again, these are not, genetic studies are not routinely recommended. Only if there is a difficulty in diagnosis, only if there's other system involvement, or the thyroid function test doesn't fit in, is genetic studies to be done in hypothyroidism. I want to stress that no screen TSH cutoff is foolproof. In our newborn screening program, we have had 2 missed congenital hypothyroidism so far. The first was 39-weeker with a mild cord blood TSH of 39.6. Our cutoff is 25, so this was screen positive. So she was followed up on day 9 and day 45. Now, if you look at it, day 45, TSH of 6.8 is not really normal, but we have not followed up further after that. But at 5 years, she presented with myxedema. At that point of time, TSH was more than 750 with very frank hypothyroidism, and a nuclear scan showed thyroid agenesis. The second child was 37 plus 2 weeker, and the cord blood TSH was 11.8, so it's screen negative, so no subsequent follow-up was done. But at 16 months, presented with short stage, poor linear height velocity and myxedema, as well as developmental delay. Once again, thyroid agenesis. So clinical examination cannot replace newborn screening. So the tendency for us is to immediately go back and see whether we missed something, whether we did not screen the baby, because both these children were born in our hospital. But clinical examination and no cutoff is actually foolproof. So learning points for congenital hypothyroidism: when you are called to see a newborn with an abnormal TFT, do not rush to start treatment. Review all the factors: age of sampling, gestational age, whether the baby was sick, had an NICU stay, whether there has any dysmorphism, other congenital malformation, and details of maternal thyroid condition. And interpret thyroid function test with caution in preterm babies. And even if newborn screening was negative, repeat thyroid function test if clinical suspicion is high. Moving on to hypothyroidism in children. I will not go through the details of this because we are all familiar with this. Most common cause is autoimmune. Of course, some of the congenital hypothyroidism like ectopia and dyshomogenesis may present later. And use of antithyroid drugs, irradiation, thyroidectomy, radioiodine, all of them contributed. And systemic diseases, cystinosis is one condition where we have seen a very high association with hypothyroidism. Once again, it's an older child. When to order thyroid function test? When there are obvious symptoms and signs, there's no issues, along with the presence of goiter. One of the most important criteria is this linear growth retardation. Very often we see that it's being done for obesity, but excessive weight gain with a poor height velocity would be more of an indication. Attention deficit, learning difficulties, and language delay, because more and more when you look at the genetic abnormalities, we see that there are certain thyroid conditions which we can miss. So we need to actually do a whole thyroid profile. Delayed puberty, of course, follow-up of thyroid malignancies, and when there's a high association with thyroid disease. In our center, we have high association. We've seen a lot of children with sodium valproate, not just subclinical hypothyroidism, also those needing treatment, as well as oxcarbazine and carbamazepine. And we know that we heard about this testicular enlargement. So when there's a discordant puberty, even yesterday we were discussing about this, when there's an absolute or relative short stature with a discordant puberty, we need to consider ordering thyroid function test. And not necessary in obesity if it is not associated with significant short stature, and non-specific symptoms like hair loss, fatigue, constipation. Very often this is how we get referrals. This may not be productive. And the biochemical diagnosis basic tests are the same. And because autoimmune conditions are the commonest, thyroid antibodies, ultrasound if indicated, and nuclear scan only if it's a thyroid nodule, you would want to delineate. And if we do TSH alone, we miss a whole lot of conditions. Subclinical hypothyroidism, a TSH of 7 or 8, whether to treat or not, we need to know the T4. Central hypothyroidism, a recent treatment with thyrotoxicosis, non-thyroid illness. So in pediatrics, TSH alone, monitoring TSH alone is not recommended. Treatment and follow-up, Dr. Vijay also referred to this, is a slower replacement as compared to our congenital hypothyroidism. Dose is lower, the requirement is lower, and we usually do a slower replacement, especially in severe untreated long-term cases. We don't want a very rapid increase in basal metabolic rate, neither do we need a very rapid advancement in bone age. So we need to do it slowly. And it's important to do not just growth, puberty assessment also at each visit. Some of the common scenarios is, a child on treatment with a mild TSH elevation with a almost high normal free T4 level. The most common condition, the explanation is compliance. So children tend to miss for several days, and they tend to take few days just before the hospital visit. And because TSH always reflects past 4 weeks of treatment. So in this condition, there's no need for dosage increase. So always interpret in with looking at all the factors together. And this mild TSH elevation with a normal T4 FT4 on treatment, so up to 43, even congenital hypothyroidism, up to 43% during infancy, a mild TSH elevation is reported. And in older children, it tends to be lower, even with treatment. A healthy child ordered TFT as she was gaining weight, diagnosed to have subclinical hypothyroidism. That is only a biochemical diagnosis for that child. And the TSH is usually not more than 10. And usually less than 10, they are likely to spontaneously normalize. So the risk of progression is only if antithyroid antibody positive, which we do particularly if there is a family history, or if the TSH is more than 10. In this situation, we need to reassure the parents and wait and watch. Non-thyroidal illness. So this is also a scenario which you would have faced. 5-year-old previously well child with a meningoencephalitis on ventilator. Despite tapering sedation, the child was unresponsive. So the ICU team did a thyroid function test. So here we see a very low free T4 with inappropriately low TSH. So in During acute illness, it's very difficult to interpret this. You can have any of these pictures in the thyroid profile during acute illness. There is no compensatory TSH rise and a low T3 level. So this is often because of the cytokine-mediated inhibition of thyroid function. And also, most of these children are on dopamine, high-dose glucocorticoid. High-dose glucocorticoid actually inhibit the conversion from T4 to T3. Dopamine also has an inhibition on the hypophyseal level, and TSH is inhibited. So the TFT changes during your non-thyroid illness is considered to be protective and adaptive. However, very low free T4 levels are reported to be associated with a poor prognosis. So during the recovery phase, we see that the T4 and free T4 normalize and the TSH is mildly elevated. Depends on when you do the repeat test after the fund. So it's important to remember that TFT should not be done in critically ill children unless thyroid disease is strongly suspected, and we need to repeat it 2 to 4 weeks after recovery. Very rarely, this scan has a diagnostic dilemma with true central hypothyroidism. Low T3 levels in this condition is suggestive of non-thyroid illness. Another scenario, which I think we discussed in the previous talk also, normal TSH and low T3 level. Treatment was started, and we found that the TSH is markedly suppressed, and the T4 is remaining the same. At that point in time, a free T4 showed high value. And thyroidin was discontinued 4 months later. Both TSH and free T4 are again normal, but the T4 level continues to be abnormal. So this is a situation of thyroid binding globulin deficiency. Not common, but could be congenital or acquired. It's important to remember that there is no metabolic effect, and this condition does not need treatment. So if you just look at the T4, and if it's in this first set of investigations itself, when we see that the T4 level is not corresponding to the TSH level, the child is otherwise clinically well, there are no features of central hypothyroidism in that, it's important to repeat the test, include free T4 in the test rather than treat and follow up the child as a case of hypothyroidism. Familiar with this condition, a 9-year-old girl with lower abdominal pain attained menarche 6 months ago. She's developmentally normal. Weight was on the 75th centile with height on the 3rd centile. Examination showed clear myxedematous features, discordant puberty, stage 3 B3 breast, already had 2 cycles with a P1, and clinically itself there was a large mass arising from the pelvis. Ultrasound showing bilateral multiloculated cysts. Actually, this child was referred from elsewhere to OG department. They had posted for surgery, but they happened to come to our OPD, and thyroid function test showed very clearly primary hypothyroidism with a strongly positive thyroid antibody. And this bone age is probably corresponding to the height age also here. Already had puberty. So discordant puberty, clearly myxedematous features, we need to consider hypothyroidism. Consumptive hypothyroidism, we do come across because we are dealing with several specialties. Infant with hepatic hemangioma, diagnosed with primary hypothyroidism. But so these are children, these vascular tumors express type 3 DIO, which converts the free T4 to reverse T3. And they need very high doses of T4. At times, we need even a combination of levothyroxine plus T3 to normalize this. It's only a clinical diagnosis along with a bicameral diagnosis of just hypothyroidism, because we don't do the marker reverse T3. And very important to monitor, because with the regression of tumor, this hypothyroidism recovers. So if we cannot give treatment very high doses for prolonged periods without monitoring the thyroid function test. The last bit of it, when thyroid function test does not make sense. So we looked at the hypothalamo-pituitary axis, and when 2 and 2, we know that TSH has to go up if the T4 is low and vice versa. And if it doesn't happen, we really do have to think about the TSH receptor, the dehydrogenases, the the thyroid hormone receptors, all of this we need to think about and start looking up. So one of the definitely identified condition is persistent a child who was diagnosed outside to have hypothyroidism was on high dose of LT4 because whatever happens, it was not normalizing, had psychomotor delay, failure to thrive, tachycardia, and biochemically has suppressed TSH with low T4 and free T4 despite being high dose of levothyroxine. So seeing this, the dose of levothyroxine was continuously increased. And in this condition, there is peripheral thyrotoxicosis with cerebral hypothyroidism. So what happens here is the T3 to go into the CNS actually needs this MCT8 transporter. So if that doesn't happen, T3 will not go in. So there is a peripheral thyrotoxicosis because we are giving thyroxine. But whatever happens, this does not go into the brain and there's a cerebral hypothyroidism. So there is a very successful treatment for this with triad. That is actually a T3 analog. So triad enters the CNS independent of this MCT8. It's an X-linked condition, and there are few children on triad being imported from outside, and these children are doing well. There are few children in our center also being treated with this condition. So when we see that very high dose of T4 thyroxine we are giving and the T4 is not normalizing, in this situation, definitely measuring serum T3 is important because persistently elevated T3 is the most consistent biochemical abnormality here. Elevated free T4 and a non-suppressed TSH. 4-year-old healthy boy, TFT was done prior to anesthesia and TSH was 7, but we see that free T4 is high. Repeated tests, similar results, and T3 is also high. Any thoughts? Yeah, tissue resistant to thyroid hormone. So at the tissue level, actions of thyroid hormone is mediated by binding of T3 to thyroid receptor. So loss of thyroid receptor function result in biochemical hypothyroidism, but function hypothyroidism. So it could be generalized, it could be tissue specific. And if you suspect this condition, it's important to measure the TSH and free T4 in first degree relatives. So it is important to remember that we should not treat this hypothyroidism because this high serum levels of thyroid hormones is made available to compensate for the receptor defect. In very young infants, levothyroxine may be given for definite indication, but dosing has to be adjusted to maintain TSH in the normal range. So I have a slide here, it's a little busy, but these are all conditions where there is non-suppressed TSH with elevated T4. One is resistant to thyroid hormones, where there's a positive family history. TSH secreting pituitary adenoma, of course. So this can be confirmed with an MRI. Familial dysalbuminemic hyperthyroxemia. Clinically, these children are euthyroid. And selenoprotein deficiency because this produces a functional deiodinase deficiency. So they present with failure to thrive, myopathy, and hearing loss. So these are specific genetic tests which can prove these conditions. So when thyroid function test does not make sense, when TSH, T4, and free T4 do not reciprocate each other, it's an unphysiological association. When the results do not fit in with the clinical findings, we need a structured approach to avoid incorrect diagnosis and inappropriate management. Clinical with a complete TFT panel, including T3, and adjunct tests, including genetic tests. To summarize, congenital hypothyroidism, newborn screening is the best option to diagnose early. Initiate treatment as soon as possible. Important to remember to avoid overdiagnosis. It can develop even if the newborn screening is negative. It's important to involve doctors with expertise to confirm and treat congenital hypothyroidism because both under as well as over treatment is not desirable. Along with newborn screening, it's also important to ensure adequate iodine intake to prevent iodine deficiency disorders. And probably we need to screen high-risk women during pregnancy because we know that up until mid-gestation, the fetus is entirely dependent on the maternal thyroxine. So it's important to maintain a euthyroid state throughout pregnancy. hypothyroidism in children. Ordering and interpreting thyroid function tests should be individualized based on history and physical examination, and never interpret TFT in isolation. And serum T3 is not routinely useful to diagnose hypothyroidism. And unphysiological association and TFT different from clinical picture warrants detailed evaluation. Thank you.